going to talk next session, and she is consultant pediatric cardiologist in Mission Hospital, Durgapur. She has done her MD pediatrics and DNB pediatrics and advanced training in fetal echo, and she is a budding pediatric cardiologist in Mission Hospital, Durgapur. Good evening, Dr. Saurabhi. Go ahead.
Okay, thank you so much, Dr. Malavika. Firstly, I would like to thank West Bengal Academy of Pediatrics for giving me this opportunity to present in front of such an august audience. My today's topic of presentation is going to be regarding the cardiac channelopathies, which is an enigma in itself. But before I delve into this topic, a beautiful sonnet by Sri Rabindranath Tagore comes to my mind, which says that Amar hiyar maje lukiye chile, dekhte ami paini tomay, dekhte ami paini. While this sonnet may mean many things to many people, but I feel that there is a relevance of these lines in our topic today, because we have many patients with cardiac channelopathies who are roaming around as normal people, and we, as well as their relatives, never know what is hidden within their hearts. And most of the times, these patients present to us in very critical condition, and we don't know what suddenly happened with them, and we are all in enigma. So this session is going to be something regarding a food for thought on these lines. Now taking you to an approach to cardiac channelopathies. Now, while walking the roads, we have to know that what is a cardiac channelopathy? It is actually a genetic disorder of the ionic channels, which actually lead to cardiac action potential. And it is characterized by altered cardiac excitability, but there has to be an absence of structural cardiac involvement. This is why they are also known as inherited arrhythmogenic diseases. Now we have to know what are the different types, what causes them, what may be the clinical presentation, the diagnostic features, and how do we treat them? Do every one of them need an ICD? Now there are multiple channelopathies, but we are going to look at some of the most common culprits like the long QT, the Brugada, short QT syndrome, congenital arrhythmogenic paroxysmal tachycardia, and arrhythmogenic right ventricular dysplasia. Now, before we look into the channelopathies, just a recap of our first year knowledge regarding the action potential of the cardiac muscle. Now, we have to remember that unlike the other muscles of our body, the cardiac muscles have a resting action potential. That means they have a resting voltage. The interior of the cell is more negative as compared to the exterior. The interior of the cell contains more amount of positive potassium ions, while the exterior contains more amount of sodium and calcium ions. So thereby, a resting cell has a negative membrane potential of around minus 90 millivolts. Now, there are certain voltage gated channels which open and close and allow these ions to come inside and outside the cell at various critical voltages. These are the voltage gated channels. Now, what happens when a cell has to generate an action potential? So there are 4 phases. The first is the resting phase, when the sodium and calcium channels are closed while the interior is beaming with potassium. Now starts the phase 0, when initially the sodium channels start becoming leaky. There is a slight rise in the potential, and then there'll be rapid sodium influx. Now with this, the interior of the cell starts becoming less negative as compared to the exterior. Now this is known as the depolarizing phase. Now when it reaches a certain critical membrane potential, which is known as the threshold, these channels slow down and there'll be transient opening of the potassium channels. Now there will be an efflux of potassium which tries to bring back the cell to its native membrane potential. But this phase is very short-lived. This is the phase 1. And then we have the phase 2, which is the plateau phase. Here, there is influx of calcium through certain calcium channels, which tries to balance the potassium efflux. Lastly, comes the repolarization phase, or the phase 3, where the calcium channel closes, but the delayed potassium channels remain open and bring back the cell to a membrane potential of minus 90 millivolt. Now, why do we have to remember this? Because this action potential is related to the QRS and the T waves of our ECG. And this action potential actually tells us about the refractory period in the cardiac cycle, when our heart muscles are relaxing. And what happens during this refractory period? The period from the phase 0 to the later part of phase 2 is the period which is absolute refractory. Any amount of stimulus cannot make the ventricular muscles contract. While the period from delayed part of phase 2 to the early part of phase 3 is the effective refractory period. Here, sometimes a wandering stimulus may generate a depolarization which may not be conducted. We have a phase 3, which is the relative refractory period, which is the reason for all types of malignant arrhythmias, where any wandering stimulus can cause a full depolarization. And we have the ending part of the T wave, which is a supranormal period. Any stimulus can actually lead on to malignant arrhythmias. With this background, let us go on to long QT. Long QT is actually a heterogeneous group of genetic disorder, which comprises of 3 main features. There is a prolongation of QT interval, which is corrected. There are tachyarrhythmias and a history of sudden cardiac death. It may be congenital or acquired. Congenital variety we are going to discuss. The incidence is around 2,500, 10,000, one out of these. But I feel that this is just the tip of the iceberg. There are 3,000 to 4,000 childhood deaths per year. We don't know many more because some of them are never determined. Now, what is the pathophysiology? Again, a recap. We have the potassium channels, the sodium channels, the calcium channel. Here, it is the pathologic potassium and the sodium channel. So thereby, we find that the potassium channels, they become underactive or loss of function mutation. And so we have a long phase 2. The sodium channel, there is a gain of function mutation. We have a long phase 0. So ion channel starts misbehaving. There is prolongation of the QT period. And then the effective refractory period is also increased. And anytime a wandering stimulus may lead to a malignant arrhythmia, most characteristic form is torsades pons. The clinical feature, most common variant is the autosomal dominant or Romano 1, and the autosomal recessive is the lesser common variant with sensory neural deafness. Now, the patient may present with syncope, sudden death, seizures, sudden infant death syndrome. How much QT is long QT? If it is more than 450 milliseconds in men and more than 460 in females. And if ever the patient experiences torsade, then it is definitely a long QT. Now, there are many genetic bases of long QT, around 17 of them. But the first 3 of them are the most culprit, out of which first 1 and 2 are the loss of function mutation of the potassium channels, while the long QT3 is a gain of function mutation of the sodium channel. Now, this we have to remember because when this sodium channel starts behaving as loss of function, we have another malignant variant, which is the Brugada syndrome. Now, when to suspect? If an asymptomatic patient comes with an abnormal ECG, suspect. If you see a second-degree heart block in a neonate, suspect. Children and adolescents presenting with sudden onset syncope, palpitation, seizure, suspect. Workup of neurosensory hearing loss, you may by chance land up with such a patient. Screening ECG after a family member is diagnosed. After a patient experiences torsade on drug, then we have to suspect. And sometimes we may be unlucky, only post-mortem diagnosis is made. Now, how to diagnose? Now, we have certain score, which is known as the SWOT score. I'm going to show it in my next slide, but we can get it from the net. I won't go much into detail. Now, that's a high-risk score. And if the SWOT score shows a risk of more than 3.5 in the absence of secondary causes, think that the diagnosis is long QT. If you have done a genetic testing and the pathogenic mutation is found, it is definitely long QT. A corrected QT of more than 500 in repeated 12-lead ECG without any secondary cause, it is long QT. If it is between 480 to 499 in repeated ECG with unexplained syncope, think long QT. So there are some characteristic ECG findings, which I'll go rush through. One is in type 1, we have a tall domed T wave, while in type 2, we have a saddleback T wave. And in type 3, we have a long isoelectric period with a dome-shaped T wave. Now, the thing that we have to remember here is not knowing regarding the presence of a U wave and T wave. Now, sometimes a U wave comes with a T wave even before the T wave touches the baseline. In that time, we have to follow the rule of the tangent. From the peak of the T wave, we have to draw a tangent which touches our isoelectric point and then take that point as the ending of the T wave and then calculate the T wave. Otherwise, we may overinterpret. Sometimes there may be tachycardias or bradycardias going on. It is better to take an estimated total at different timings, like 3 different ECGs if your patient is having episodes of tachy or brady, because heart rate changes are going to bring about changes in the corrected QT. Now, this is one example of the characteristic torsades points, which means twisting around the axis. Here we can say that there is a ventricular tachycardia where the electrical potentials are varying across the isoelectric point. So this is one of the characteristics. If you see one, recognize it. Now, another just a small nugget that I would like to share is that if we don't have we don't have the time for Bazit's formula, what we can do is see the ECG and see whether the QT interval is more than 50% of our RR interval. If so, definitely suspect that you're dealing with prolonged QT. Now, this is the SWOT score. I'm sorry. Now, here we have to lay stress that there are certain things we have to ask the patient. One is regarding the history, syncope, family history, and certain ECG changes. A score more than 3.5, think about long QT, and genetic testing is a class 1 indication. Now coming to triggers. Now there are certain triggers like swimming and exertion for type 1, auditory triggers like the phone call, a very high volume electronic doorbell, sleep or rest may trigger long QT type 3. Now, this is a list of the drugs like sotalol, quinine, or the usual antibiotics like azithromycin, clarithromycin, or ciprofloxacin, which should not be given in patients with long QT. Now, coming to the treatment, beta blockers are the drug of choice. You have suspected, you start with beta blocker. Nadolol, drug of choice. We do not get it, start on propranolol. How do you titrate? Bring the heart rate to 25 to 30% reduction from the maximum heart rate. Other option, left cardiac sympathetic denervation and ICD implantation. Better send them to a EP specialist who is going to take the decision regarding these two modes of treatment. Coming to the next variant, Brugada. It was first described by the Brugada brothers in 1992. It's an autosomal dominant variant with variable penetrance. 20% risk of sudden cardiac death. The most common mutation is in the SCN5A, which I had already discussed and here there is loss of function mutation of the alpha subunit. There are 60 different types of mutation associated with Brugada. Now, what is the pathophysiology? Actually, there is a transient outward current, that is the potassium current, which goes outside during phase 1, giving rise to a notch appearance in the action potential. In patients with Brugada, this notch is more prominent in the epicardium versus the endocardium. Now, the presence of a prominent AP notch in the epicardium, but not in the endocardium, gives rise to a transmural voltage gradient when the ventricle is repolarizing. Now, this leads to elevation of ST segment. And now, why elevation of ST segment? Because in the words of Sir Brugada, you have to think about Brugada syndrome when you find an ECG with incomplete RBBB and persistent ST segment elevation in the anterior precordial leads, that is from lead V1 to V3, in a structurally normal heart with J point elevation and propensity for life-threatening ventricular arrhythmia. Now remember, it has a striking male preponderance, typical onset between 30 to 40, but it is also seen in infants. And there may be major cardiac events like syncope or sudden cardiac death. A patient may never wake up from sleep, and it may be triggered by hyperparexia, excessive alcohol consumption, and large heavy meals. Actually, there is a famous story by which this syndrome was also known as sudden unexplained nocturnal death syndrome, where the males in Vietnam would not sleep at night in fear that they would never get up in the morning. Think about it. Now, there are certain special ECGs in Brugada which just help us with the diagnosis. Now, the type 1 is a coved type ST segment elevation. Here, the things to be noted is that there is a typical ST segment elevation with the J point elevation of more than 2 millimeters, and then there is a slope and the T wave is always inverted. While in type 2 and 3, they are saddleback type with less elevation of the T wave. That is more than 1 millimeter, in type 3 less than 1 millimeter. Now, none of them have the propensity to actually diagnose when there will be a coming arrhythmia. Now, diagnostic criteria of Brugada. Diagnostic criteria, you have to remember, if you see a type 1 variant of ST segment elevation in the right precordial leads, and you have documented VF or polymorphic VT, any form of family history, presence of cove type ECG in the family members, nocturnal agonal respiration, think Brugada. And you have to alert the patient. Although drugs like quinidine have been said to have some role, but more or less you have to be under the monitoring of a EP specialist. Now, ICD recommendations, prior sustained cardiac arrest or sustained VT, yes. Spontaneous type 1 ECG with history of syncope, yes. Inducible VT or VF or EP study may be considered, but in other cases, there is no need. Coming to short QT. Short QT is a relatively newly discovered arrhythmogenic disease in 2000, and it is characterized by paroxysmal atrial ventricular fibrillation, syncope, and sudden cardiac death. Now, mutation in 6 different genes are known, and basic pathology is that there is increased activity of the outward potassium currents, that is in phase 2 and 3. Now, this leads to shortening of the action potential in phase 2. And this causes shortening of the overall action potential. Now, since we have very few patients, only 29 patients by Casio, Gastio et al. Said that 62% of them were symptomatic, out of which 34% had cardiac arrest, Rest had palpitation, syncope, or fibrillation. Now, we do not know how much QT is short QT. So Viking et al. Suggested that if the QT interval is less than 330 in males and less than 340 in female, think that it may be short QT, or less than 360 in males and less than 350 in females with history or with family history or symptoms of palpitations, maybe like arrhythmias, then we can think about short QT. Now, there is a proposed diagnostic criteria of short QT syndrome. This we can get it from the net. But what I would like to show you is the characteristic ECG, where you can see that the QT interval is definitely very short, and thereby it has got a propensity of developing arrhythmias. Now, coming to the management, short QT ICD implantation is recommended both for primary and secondary prevention. Now, pharmacological therapy with QT prolonging drugs are necessary. Some drugs like quinidine, disopyramide, amiodarone are found to be beneficial, although the number of studies and the number of subjects in the studies are very less. Now, class 3 agents like ibutylide and sotalone, theoretically useful agent. I'm sorry. Now, next, coming into the topic of our next type of arrhythmia, let me discuss this patient, which I think we all know, Christian Eriksen. He's a very famous Danish football player. And in Euro 2020, UEFA, he suffered with a major cardiac arrest just after 1 hour of the play. And we all know that he had to be taken, he was given shocks, and then an ICD had to be implanted. So these are some of the scenarios which we hear of or see in the newspapers, or maybe sometimes we come across in our patients. So this is one of the important entities which we have to remember, which is CPVT, that is catecholaminergic polymorphic ventricular tachycardia. Now, what is this? This is a disorder of intracellular calcium handling, which is mediated by adrenaline. That is, it is adrenaline-dependent arrhythmia. Now, the affected patient may have history of stress-induced syncope or history of juvenile cardiac death in the family. Stress means adrenaline. Patient presents with life-threatening VT or VF, and it may be during strong emotional instances or maybe some physical exertion. Now, this VT may be bidirectional or polymorphic, like during exercises where we have an adrenaline surge. And this is mostly found in players where we see the news of sudden cardiac death. Now, what is the genetic basis? This is predominantly an autosomal dominant form. Now, there is mutation in 2 genes primarily. One is the ryanodine receptor gene and another is calcicrystrin. Now, calcicrystrin is actually an autosomal recessive form of mutation. So these proteins, they actually mediate the release of calcium from the sarcoplasmic reticulum, which is required for myocardial contraction. And any form of abnormalities in these genes will lead to excess calcium leakage and thereby propensity for depolarization and thereby arrhythmias. Now, what is the ECG and clinical features? They present in childhood or adolescence as syncope or sudden cardiac death. Now, normal baseline ECG, this is something to be thought about. Exercise-induced bidirectional VT. EP study does not provoke arrhythmia, and catecholamine transfusion may be helpful to unmask the disease. Now, this is a bidirectional VT where we have beat-to-beat variability of the QRS axis. One is a positive axis and the other one is negative alternately. So this is one of the characteristic ECGs which, if we see, acts as a spotter to diagnose this variant. Now, treatment. Avoid competitive sport because competitive sports lead to excessive catecholaminergic surge. Beta blocker for all patients with documented arrhythmia. ICD when the patient is on beta blocker yet having symptoms. Flecainide and verapamil for patients with ICD and beta blocker with symptom. And the last resort will be left sympathetic denervation for patients who remain symptomatic even after management. Now, this decision has to be taken by an EP specialist. Now, lastly, coming to arrhythmogenic right ventricular dysplasia. Now, this is a heritable cardiac muscle disorder affecting predominantly the right ventricle. Now, we have to remember and think about this disorder because this is one of the cardiac channelopathies which can be easily diagnosed on echocardiography. We have something that we see in a picture along with the ECG, which helps us in making the diagnosis. What is the hallmark? The hallmark is fibrofatty replacement of the right ventricular myocardium. Now, majority of them are caused by defects in the desmosomal protein. Now, what is this desmosomal protein? It is actually the adhesion protein between the cardiac myofibrils. Now, once this desmosomal protein starts behaving abnormally or is deficient, those areas in between the myocardial cells are filled up with fibrofatty infiltration. Now, this leads to a form of structural abnormality of the RV myocardium, and this may generate ventricular arrhythmia. So we have to remember here that the RV is the major source of the arrhythmia, and within the RV also, it is the RVOT which is the major source of the arrhythmia. Now, what may be the presentation? History of syncope, as we know, due to transient cardiac arrest. There may be recurrent arrhythmias not suppressed by antiarrhythmic therapy, and the patient may be on multiple antiarrhythmic drugs. A family history of cardiac arrest in first-degree relative, effort intolerance, complaining of lightheadedness anytime, palpitations, chest pain, which are unexplainable. Now, one of the characteristic ECG finding will be the epsilon wave. Now, epsilon wave is actually a marker of after depolarization potentials originating from the RVOT in the right ventricle. It is more specific finding, but we have to remember that it cannot predict when this patient is going to have an episode of sudden cardiac death. So it does not have a good predictive value. There may be T wave inversion in lead V1 to V3, prolonged S wave upstroke, localization of the QRS widening of around 110 milliseconds in the left precordial leads of V1 to V3, and paroxysmal episodes of ventricular tachycardia with an LVBV morphology, which is known as right ventricular VT, that is RVOT-VT. So this is one of the characteristics. Now, diagnosis. Now, echo has got a very good role in diagnosing ARVD because it demonstrates a dilated hypokinetic right ventricle with prominent apical trabeculae and dilatation of the RVOT. Now, although modality of choice is going to be the cardiovascular MRI because it can show us the fibrofatty infiltration, the thinnings, the aneurysms, dilatations, regional wall motion abnormalities, everything. But CT scan and right ventricular contrast angiography may suffice. Histological diagnosis by taking biopsies and genetic testing are always the gold standard. Now, what is the treatment? Treatment start with beta blockers as the first line therapy. Surgical ablation may be useful in some cases, but not all. Complete electrical disarticulation has been described, but not much is given when we look into the case studies. And ICD placement is another option. Now, before I conclude, and I have literally flown through my slides to take you into this very difficult topic, which is always an enigma. I would like you to ponder on certain takeaway points. Please go back to your home with these minute details. That is, do not ignore the fall in your patient. A fall has to be taken very seriously because you never know. The heart may be structurally normal, but you may be dealing with a potential arrhythmogenic heart. And the second time, the patient may not give you a second time, he may be coming as dead. All cardiac channelopathies have certain classical ECG findings, which are never related to the risk stratification, but they help us in identifying these malignant disorder. If we see these classical, if we just try to remember some of them and see them and try to find them in the ECG, maybe we save a life. Genetic testing in suspected cases is class 1 indication. Go for genetic testing. It's never going to harm. And once you diagnose a patient, go and screen the family members with genetic tests because you may be preventing a sudden cardiac death in their family. Sports person who come to you for clearance, get them tested, even if you have an ounce of suspicion that they may be having an underlying arrhythmogenic heart. And ICDs are not mandatory. Do not spread the misconception that ICD is the treatment or cure for all cardiac channelopathies. Drugs are still our first option. We have to start them on drugs. And once you identify the patient, keep them on good follow-up with you and also consult them to specialists like the EP specialist who will be able to give more insight into what is going on in this heart. Do a detailed follow-up, explain the risk, do a genetic counseling, and keep the family under your confidence that you are there for them and you're not going to let them fade away. Thank you so much for your patient hearing. Hello?
Yes,
Yeah.
Malavika, Lopa, are you there?
Yes, sir. Thank you, Dr. Saurabhi, for your nice, lucid deliberation of such a difficult topic. Our next speaker is Dr. Joyitri Mojumdar. She is Associate Consultant of RN Tegar Hospital. She has done her MD Pediatrics and DRNB Pediatric Cardiology from India. and she has also multiple research papers, and she is also a reviewer of multiple research papers. Please welcome Dr. Joyitri Majumdar.
I
Please go
request
ahead.
Dr.
Am I
Dr.
Saurabhi Das to
Saurabhi,
answer the questions in the chat box. Dr. Saurabhi Das, please answer the question in the chat box. There are a few questions in the chat box.
Sir, I'll have to write.
Yeah.
yes, yes, you write in the chat box, because today is we are a very tight schedule, so we are not directly discussing the question. You just write there in the chat box, please. Okay.
Hello, am I audible, sir?
Yes, yes.
Should I start then?
Go to the slideshow mode. Okay.
Yes. Is it all right, sir? Should I start?
Yes, ma'am, you can start.
Thank you. So good evening, my respected teachers and my colleagues. And I thank, first of all, to WBAP to give me this opportunity. And today I will discuss the developmental changes in ECG, which is a very dry topic. And I think most of the points have been elaborated till now. So I am just keeping my initial slides, which describe the conduction system and the hexaxial system and indicators of pediatric ECG. When do we do the ECGs during tachyarrhythmia, bradyarrhythmia, seizure, cyanotic episodes? These are the initial slides. I'm quickly going to my main topic, that is pediatric ECG characteristics. So the pediatric ECG, the heart rate is faster, and all durations and intervals like PR interval, QRS duration, QT interval are shorter than in adult. There are two waves, normal Q wave in inferior and lateral leads and RS adverse pattern, which is very physiological in V1. And sinus
Slides are
arrhythmia
not
is present.
moving. Excuse me, your slides are not moving, and make it into full screen mode. Left upper top, fourth icon, you just click that.
Sir, can you see?
No. Go on the left upper top, and then the fourth icon, you just click the fourth icon. Make it a full screen. Anyway, you continue then. Now the slides are moving, you continue.
Moving, sir. My slides are moving. Can you see?
Yeah, your slides are moving. You can continue. Please go ahead.
Yes, yes. Thank you. So the transition from fetal to neonatal circulation is some features that we consider abnormal in adult ECG are completely normal on a child's ECG, and they may vary by the age of the child. In the fetus, the circulation through the lungs is mostly bypassed due to the patent ductus arteriosus. This means that there is a right ventricular dominance. The right ventricle is larger, thicker than the left ventricle. After birth, the PDA closes and the left ventricle gradually becomes dominant. So what are the developmental changes? There is gradual decrease in the heart rate, increase in the P wave duration, PR interval, and the QRS duration. QRS voltage is
Just
low
to
in the first
interrupt-
few months of life.
It's just to interrupt, Dr. Joyitri, your slide 10 is showing on the now in the screen. Slide number 10. So go to the original slide that only you are talking on.
So actually I am moving here, but there is some lag. I think I cannot get it. So
Continue
Slide
like
number you are okay.
continue. You continue like this. Okay.
sir, which slide are you seeing, sir? Please.
11.
The transition from fetal to neonatal?
Yeah.
Yes.
Yes. Then I am proceeding. Thank you.
Okay.
Sorry for the interruption. Yes. This is the next slide, the developmental changes in pediatric ECG. Can you see, sir? The next slide is slide
You
number
can see
12.
the slide, but it is not in the slideshow mode. If you face any problem, continue like this. That will also serve the purpose. Please continue. Dr. Joyitri, please continue.
Yes, sir. Yes, sir. By 3 years, the child's ECG resembles that of the young adult. First, I am going to the neonate. In a neonate, the axis is rightward. That is, the lead 3 will have a tallest upright QRS, and lead 1 and AVL may be negative, short or biphasic, with the axis usually greater than 75 degrees. Now, there is dominant R wave in lead V1 to V3 because there is RV dominance, and there is RS R' pattern with narrow QRS in V1, and there may be right bundle branch block, that is incomplete RBBB pattern, and Q waves are normal in inferior and left precordial leads. As we all know that the septal depolarization is from left to right, so the Q waves we can see normally in 2, 3, AVF and V5, V6. Now the heart rate in the newborn is much faster and peaking at 3 to 8 weeks of age. The usual resting heart rate of the newborn is 90 to 190. The normal ranges vary greatly among the references and rising with activity such as crying. The cardiac output, because of the small volume, ventricular volume, the neonatal cardiac output is maintained by the faster heart rate. There are some intervals, there is a PR interval, the QRS duration, which are very much shorter, relatively shorter than an adult ECG. And due to smaller heart size, the QRS may be as short as 30 milliseconds, making the QRS complex very narrow. The PR interval may be as short as 80 milliseconds. And with faster heart rates, that is in tachycardia, that is when the child is crying, the intervals are much shorter. There is T-wave inversion, which is a juvenile T-wave pattern in V1 to V3. That is usually occurs during the first week of life and continues until just before
Hello,
the
excuse
adolescence.
me, Joyitri. Sorry to interrupt you repeatedly, but you're the same slide number 12 is on the screen, is not changing.
So should I stop sharing and then share? I cannot understand what is happening.
Stop share and then restart, I think. Yes.
Okay, sir. Is it visible?
It's coming now. Yes, it is neonates.
Yes, sir. The
Slide
previous
number
slide
14.
is. Yes. Sir, I'm just going through the main slides then, repeating the neonate.
Yes, start from this, where you start from that slide only. Not required to from the beginning.
Yes, sir. Just doing that. There is T-wave inversion, there is juvenile T-wave pattern in V1 to V3, usually during the first week of life, and continues like this just before adolescence. However, this pattern of T-wave inversion may persist until early childhood. The sinus arrhythmia, that is the rate fluctuates with breathing, is present in neonates. So this is a neonatal ECG. We can see the heart rate is around 130 to 145, and there is tall R waves in V1 to V3, and biphasic T wave, that is the biphasic T wave, initial in inverted T and followed by the upright. This biphasic pattern is seen in V1 to
Extremely
V4
sorry,
in a
Dr.
newborn.
Joyitri. You were just speaking, but we cannot see the ECG stream. Please go in the slideshow mode. You take time. Go to the slideshow mode so that it will be convenient for all the attendees to see it.
I can share the slide for you if you want. Just
please do it, Mihir. Please do it.
Then you stop
No,
share.
sir, I have modified. This slide is not with you, sir.
Make it in the slideshow mode.
Is it visible? I have already made it.
Visible, but make it in the slideshow mode.
The
Yes,
upper panel, in the in the upper panel, you can see in the right side from the beginning, the save button, then you can see the slide. So yes, now I think it's coming.
Yes.
Is it
slide?
visible?
Yes. Again, not in the slideshow mode. Just listen to me in your screen. Go to the top. Your car. Go to the top. Extreme top. Left side. Then go to the left side. Where is your cursor? Yes, extreme top.
There is one save.
Top your screen, not in your.
Sir.
Anyway, Mihir, I think
I think Joytri, you send your modified slide to Dr. Lopa or Dr. Malovika. They will do from share the slide from their end. Then you will have to start again. I'm sorry to interrupt, but we can start the.
I'm also seeing this, sir. I cannot help you because I'm trying. And
yes, we can start the next. Then you will restart. You will get your. Just take your time. Okay.
Okay, sir.
Okay. Malovika or Lopa, just introduce the next topic and the speaker and go ahead, please. Malovika, are you there?
Yes, sir. Yes, sir. Our next speaker is Dr. Soumyakantri Mohapatra. He is Associate Consultant in Department of Pediatric and Structural Heart Disease, Medica Specialty Hospital. He has done his DNB Pediatrics and FNB Pediatric Cardiology from India. Welcome, Dr. Soumyakantri Mohapatra.
Good evening, ma'am.
Go ahead.
Am I audible?
Yes, sir. Yes, sir.
Yeah.
Yes, visible perfectly. Yes. Go ahead.
Good evening, all. At the outset, I would like to thank the organizers for inviting me for this talk. And I would be discussing on narrow complex tachycardia. Before starting off with tachycardia, when I was told that I'm supposed to be talking on tachyarrhythmias, I myself had started having tachyarrhythmias because it's a huge responsibility to be discussing this because it seems to be quite simple, but it actually isn't. But what's important for us is to do the basics right. So tachycardia is common in children, and by definition, it is something like a heart rate which is more than expected for age. Usually it's benign, but what's important is it requires to be addressed. And the reason is persistence of tachycardia can cause a decreased ventricular filling, decreased cardiac output, thereby leading to heart failure, circulatory collapse, shock, etc., etc. So when we talk about narrow complex tachycardia, what we mean? It's basically an ECG-based diagnosis where the QRS duration is 120 milliseconds in adults, but as per the PALS guideline, it comes to around 90 milliseconds or less. And commonly, we associate narrow complex tachycardia with supraventricular tachycardia. But the fact of the matter is there are certain types of ventricular tachycardias also which may come under narrow complex tachycardia. But for the simplicity's sake, I would be more likely to be presenting and discussing upon the supraventricular tachycardia. Now, this kind of a tachyarrhythmia is a kind of a rhythm process which occurs maybe in the atria, in the AV nodes, or in the His bundle. And that leads to the ventricular depolarization. And that's what we see. Arrhythmias have basically three mechanisms. So one is the automaticity, the other is the trigger activities, and the third is the re-entry. Automaticity is actually normally a decremental conduction system, which happens based upon the sinus node, SA node, the AV node, the His bundles, and the Purkinje fibers, and so on. But what's important is there might be abnormality in the automaticity, which can be caused due to ischemia, or it can be due to a catecholamine induced issue as well, which has already been discussed in the previous talk. When we talk about the trigger activities, it is basically relating to the hypoxia, the acidosis, and the biochemical parameters derangement, which might lead to an early after depolarization, or it can be a delayed depolarization. When we talk about a delayed depolarization, most likely this is a drug-induced thing, and digoxin is a common offender. But what we are going to discuss upon is about the re-entry tachycardia or the re-entrant tachycardia, which comprises of almost 90%. And most of them are either macro or the micro re-entrant mechanisms involved. Okay, so when we talk about the re-entrant tachycardia, there are basically two separate conduction pathways. One is a slow and the other is a fast pathway. And most often than not, there will be a unidirectional block, which leads to a continuous electrical impulse traveling in the loop. If in the right side of the animation, if you see, there is a re-entrant impulse which occurs via fast pathway in a retrograde direction. That is what leads to the re-entry, and that's what is known as the AVNRT, or the atrioventricular nodal re-entrant tachycardia. Whereas on the left side, if you see, there is an accessory pathway along with the normal pathway, which is the SN node AV node pathway. And here what happens is there is a re-entrant impulse which is generated, and that goes through the accessory pathway in the retrograde direction, causing a QRS narrowing, which is what we call as a AVRT. There are two pathways. One is the orthodromic pathway, the other is the antidromic pathway. When you have a normal AV node pathway, which is orthodromic, that causes regular narrow QRS tachycardia. But when it comes to an antidromic AVRT, what happens is there is antegrade pathway through the bypass tract, and there is a retrograde AV node passage of electrical conduction. This causes wide QRS complex tachycardia, which I'm not going to be discussing because we are focusing primarily upon the narrow complex tachycardia. So how do we go about next? It's scary pretty, right? So first and foremost, what's important for us is to be having a proper clinical examination, which comprises of a thorough history as well as a physical examination. But of course, ECG is the cornerstone of the diagnosis. And ancillary to this, we also might require a chest X-ray and an echo to be done. So what's next? As most of us are pediatricians and we are well aware of the PALS guidelines, we suggest that we must always rule out a 6H and the 5 Ts, which I'm not going to discuss in details. But in the initial assessment, of course, the airway, breathing, circulation of the ACLS thing, and then you come across the 12 lead ECGs, which are primarily the crux of what we are going to plan for the diagnosis as well as further management. Now, this is the most important slide of my talk today, because this is what is required to be for planning accordingly what should be the diagnosis, what is the etiology, and how we are going to plan the management. So when we come across a case who has got a narrow complex tachycardia, of course, the RR interval regularity should be monitored first. Then you look for any presence of P wave. Now, if the P waves are present, we need to look for the atrial rates, the P wave morphologies, the atrium and the ventricular relationship based upon the P waves followed by the QRS, is it there or not? And also, we need to look for the P wave position in the cardiac cycle. That is what you call as the RP and the PR intervals, short RP and long RP. Now, based upon that, the narrow complex tachyarrhythmias are divided into the regular ones and the irregular ones. The irregular ones are the flutters, the fibrillations, the multifocal atrial tachycardia with variable blocks, But the regular ones are most likely seen in the normal day-to-day practice, especially in the emergencies, where you get a AVRT or a AVNRT or a PJRT. Now you must be observing that there are certain DDs which have been highlighted in red. What I meant by doing this is these are the types of the regular tachyarrhythmias which are AV node dependent, which means that these are the ones where if you add upon those drugs which can cause AV block, they might work, they might help. So when you come across the ECG findings and the P waves are visible with a short RP interval, maybe less than 70 milliseconds, then most likely they are due to the AV and RT group. But if you find the RPs are short, but little more than the 70 milliseconds, then they could be due to atypical AVNRTs or AVRTs. The long RPs are the sinus tachyarrhythmias, the atrial tachycardias, and the PJRTs. The PJRTs are nothing but these are one of the subtypes of the orthodromic AVRTs. And if at all you have no presence of any P waves, then most likely this is an AVNRT or having a junctional ectopic tachycardia. So this slide in brief is about AVNRT group, where these are most commonly they respond to vagal maneuvers. Around 60 to 80% they respond to vagal maneuvers. 1/3 of the patients might have the pseudo R waves in the V1, the pseudo S waves in the inferior leads of 2 and 3. If you see the picture in the right side, this is of lead 2. If you find no P waves, it is out and out clear that this is AVNRT. But if you find a pseudo S wave, which is a negative deflection just after the R wave, which is seen in 30%, most likely this is due to an AVNRT. You might get a pseudo Q wave as well, but these are hardly 4% cases you might find. But you can get a retrograde P wave after the QRS complex, which is rare. But when you find a retrograde P wave, most likely these are AVRT group. Now, 60% of those cases don't have any P waves. They are very responsive to AV nodal block agents, as I earlier mentioned. Recurrence are the norm in the medical therapy. But what's important for us is if at all we go for a EP study and a radiofrequency ablation, and 95% cases have successes and only 1% there is a complication. Now coming across this 12 lead ECG, what we see is there is a narrow complex tachycardia with a rate of 200, which is almost irregular, and the P waves are not visible. So this is a supraventricular tachycardia. The possibilities are AVNRT or junctional tachycardia. Now coming across to the AVRT. AVRT, as I mentioned, we will be dealing with the orthodromic ones where we have a anterograde AV node conduction and a retrograde accessory conduction. So in this case, we have usually the RP intervals are short than AVNRTs. Okay, so if the P waves are detected with STT changes or QRS alternates, they are most likely to be AVRTs. By QRS alternates, if you see the picture, you will be clearer that the amplitudes are fluctuating in an alternate manner, and that's what you call as a QRS alternate. Frequently presents in patients with WPW, where it usually presents as AVRT, and when we give some vagal maneuvers or say AV blocking agent, then it unmasks the WPW pre-excitation ECGs. This is a patient who was a female patient, had issues of gastroenteritis, suddenly found to have an onset of tachycardia and the ECG monitor. And this is what we find as a narrow complex regular tachycardia. And the heart rate is somewhere around 300. If you observe, there is a P wave and the RP interval is long. Now, how do you compare, how do you distinguish whether the RP interval is long or short based upon the RR interval? If you see, the RP interval is more than 50% of the RR interval. So this is most likely due to an AVRT. Now coming to the atrial tachycardia, they are a type of narrow complex tachycardia, so where the P wave morphology is different from the sinus node. They can be focal, they can be atrial flutters, they can be fibrillations, but in those cases where you have flutters and fibrillations, they have irregular narrow QRS complexes. So this one is an example of a 14-year-old anxious adolescent boy coming to an ER with a sudden episode of palpitation. And this is the ECG what we find. If you see, there is a narrow complex tachycardia. Rate is around 40. There are inverted P waves, if you notice, in the lead 2, 3, as well as in the AVF. So along with a short PR interval. So this is probably an etiology of atrial tachycardia. Now moving on to the WPW syndrome. This is nothing but this is a pre-excited pathway, which is symptomatic in terms of dizziness, or it could be due to palpitation, or it can present with some kind of a non-specific symptoms. With what's important is there will be an accelerated AV conduction with a PR interval less than 120 milliseconds, prolonged QRS, the widened QRS, with an abnormal slurred upstroke of QRS or the delta waves. Abnormal depolarization and repolarization leads to a pseudo-infarct pattern. But what's important is these slurred upstroke or the delta wave which is created is basically due to the ventricular depolarization by the accessory pathways. In addition to that, there is a cumulative to that is the normal AV conduction pathway, and that leads to the widened QRS complex. So this is what the ECG will look like. A 17-year-old girl with episodes of palpitations lasting for a few minutes. And if you see that the PR intervals are short, less than 20 seconds, the QRS are wider with a slurred upstroke, delta wave. So WPW. Now coming across to the atrial flutters, they are mostly reentrant. They have a mechanism which is macro, and these are the ones who basically involve the cavo-tricuspid isthmus, which causes either a counterclockwise or a reverse loop. When we come across the word called counterclockwise, they are the typical atrial flutters where you will be finding 2, 3, and AVF, or the inferior leads having negative P waves. A 2-day-old female admitted for respiratory distress having an abnormal ECG rhythm. If you see, there is a narrow complex tachycardia. The RR intervals are irregular. The P waves have got a different morphology in sawtooth pattern. So this is flutter with variable block. Most likely this is a 2:1 or 3:1 block. This is the sawtooth appearance, the image of a sawtooth, and that's what it looks like. So the diagnosis is quite easy based upon the led to things. Moving on to the next slide, we have a 17-year-old with history of palpitation. And here you see there are irregular RR intervals, but there is no discrete P wave. Okay. So when you find that there are no visible discrete P waves with irregular RR intervals or irregular heart rate, so most likely your diagnosis will be atrial fibrillation. And what's more interesting is when you come across the V1 lead, there will be wide QRS complex with aberrations and the long pause, and that's what's called as Ashman's phenomenon. This is basically the recap of the mechanisms. Where you have a sinus rhythm. Sinus rhythm has got a normal rhythm, which basically conducts impulses to the AV node and thereby through his bundle to the Purkinje fibers. But whenever you have an ectopic tachycardia, you have discrete different atrial foci, which causes AV node conductions, and thereby you get different morphology P waves. When you have multiple discrete atrial activities, there you have the multifocal atrial tachycardia. And when you have a macro entry of the what do you call the atrial impulses, that causes the atrial flutters. And of course, AV-NRT, as we have already discussed, that will be somewhere around the AV nodes with a fast as well as a slow conducting pathways, and any kind of unidirectional blockage would lead to this re-entry, and that causes the AV-NRTs. Junctional ectopic tachycardias will be dealt with in the next talk, because this is most commonly associated with post-cardiac surgeries. The AVRTs are the ones where you have a normal conduction pathway along with the accessory pathway. And of course, the PJRTs, they are the subtypes of the AVRTs. Yeah. So here I'm just going through a few slides where you see a narrow complex tachycardia with a regular interval rhythm with a heart rate of around 170. There are inverted P waves in the inferior leads, but if you closely observe, the RP is prolonged. It's more than 50% of the RR interval. So most likely this is a PJRT, but if you call it as AVRT also, that won't be wrong. This one is a narrow complex tachycardia again, with a rate of 225 per minute, a retrograde P waves with a long RP, AVRT. So this is another narrow complex tachycardia, regular interval, 220 heart rate, long RP, AVRT. This one has got an absent P wave, so most likely this is AV-NRT. This one had an absent P wave, but what you find here is in the V1, there is RS R' pattern, which is an incomplete RBB feature, and this is SVT with aberrancy. This was a patient who had come to us recently, probably 1 week back, had come to us with tachycardia. His rhythm was somewhere around 260s. So what we did was we administered adenosine, but there was no response to that. And then we again gave a second dose of adenosine at 0.2 mg per kg. And this was the ECG. Forgive me, the ECG is not very clear, but what is seen here is again P, which is possibly been unmasked by the administration of the AV nodal blockade. And this was basically an atrial tachycardia with variable block. So how do we manage these patients? Basically, it depends upon the hemodynamic stability. If you find the patient is stable, then the primary target of us would be to terminate the tachycardia by means of giving all AV nodal blockade agents, which could be adenosine, either beta blockers or calcium channel blockers, amiodarone, flecainide. But when we think about giving flecainide, one thing we must be sure, and we must ensure rather, that the structurally the heart is normal. It is
sorry to interrupt, sir. 2 minutes more, sir. Time is very less in our hand.
Sure, ma'am. I am done. I have another 2 slides.
Okay, okay,
no issues, ma'am.
Okay.
Along with the rate control, if you find there is the hemodynamically unstable patient, then you go for a cardioversion. If there is a refractory tachycardia with incessant tachycardia, then you might think of EP study and RFA. So what are the today's learnings? So basically, we are looking for a systematic approach for a narrow QRS tachycardias. And as I mentioned in my 5th slide, which is more important, is to look for the features in the ECGs. And there has to be an individualized treatment based upon appropriate diagnosis, which yields better outcomes. So what's important is to do the basics right. And last but not the least, I would like to pay my tributes to all my gurus, my mentors, my masters, who have been part of my journey. So thank you all, and thank you all for a patient hearing. Thank you.
Thank you, sir. Our next topic is wide complex tachycardia by Dr.
I think Malavika.
Am I audible, sir?
Yes, I think if the Joyitri is ready, we can start with her presentation. Then we can go to the narrow complex, wide complex tachycardia. Okay.
Okay, okay.
Is there
Yes,
any
sir,
question? Okay, then
Are you
I am
ready, ma'am?
sharing the slide.
Okay.
I'm very sorry because I cannot share due to some technical glitches.
No,
Please
no,
forgive.
ma'am. It can happen anytime with anybody. Yes, ma'am.
Is the screen visible?
Yes, visible, ma'am.
Yes, yes.
From which slide you want to tell?
Slide number 11, Meeta. Yes,
This one?
yes.
Yes.
The next slide. The next slide. The slide after this. Yes. Thank you for your patient hearing. I'm again very sorry. So now I am going directly to the developmental changes in pediatric ECG. There is gradual decrease in the heart rate as the age progresses. And there is also increase in P-wave duration, PR interval, and QRS duration. The QRS voltage is low in the first few months of life, and the mean QRS axis in the frontal plane moves in a direction from right to the left gradually, because we all know that after birth, the RV is dominant, as during the fetal life, the duct actually carries most of the blood. So the RV is dominant, and as age progresses, the LV becomes dominant. So by 3 years, the child's ECG resembles that of a young adult. Next slide, sir. Next slide, sir. So in neonates, the axis is rightward. In lead 3, we see that there is tallest upright QRS, and in lead 1 and AVL, these leads are negative. The axis is usually greater than 75 degrees. Sir, please proceed. Dominant R wave leads V1 to V3. This is because of the relative larger size of the right ventricle, and there may be RS address pattern with narrow QRS in V1. This is incomplete RBP pattern, which is physiologic for the newborn. And right bundle branch block has an RS address pattern with a wide QRS complex. Q waves are normal in inferior leads and also left precordial leads, that is 2-3 AVF and V5 V6. Now the heart rate of the newborn is normally much faster than the adults, peaking around at 3 to 8 weeks of age. The usual resting heart rate of the newborn is 90 to 190 beats per minute, though the range may vary, and during crying and during any pain, this rate may again vary. The next slide, sir. Because of a smaller stroke volume, the cardiac output, to maintain the cardiac output, the heart rate is a bit faster. As we all know that the stroke volume is the heart rate cardiac output. So shorter intervals at PR interval and the QRS duration tend to be shorter due to smaller heart size in neonates. The QRS may be as short as 30 milliseconds. In normal adults, we all know that it is 2.5 small squares. And if it is less than 100 milliseconds, then we call it normal. But in newborns, it is normally 30 milliseconds. And the PR interval may be as short as 80 milliseconds because of the faster heart rates. And there is T-wave inversion. It is called juvenile pattern, present in V1 to V3, and usually occurs during the first week of life and continues till adolescence. However, this pattern of inversion may persist until early adulthood, mostly seen in the sports person. There is also sinus arrhythmia, that is the rate fluctuating with the breathing. Next slide, please. So this is the pictorial demonstration of a 2-day-old infant. We can see that there is sinus rhythm, normal sinus rhythm. Heart rate is around 130 to 135. There is right axis deviation and dominant RV, right ventricular voltage from V1 to V3. That is, the R wave is more than the S wave. And also, there is biphasic T wave in V1 to V4. The T wave is initially downward, then it is upward. So it is biphasic pattern. Next slide, please. So there are some subtle changes as the infant grows, as the newborn enters the infancy or the early childhood. The ECG begins to become more reflective of left ventricular dominance pattern. The axis moves leftward, the R wave changes, the R wave in V1 to V3 become more normal and shorter than the S wave. That is, the ratio of R is to S becomes equal to 1. Initially, it was more than 1. Now, Q wave amplitude, Q wave in inferior and the left precordial leads peak in the amplitude at about 0.6 to 0.8 millivolt at around 3 to 5 years. Now, there is a chart that the heart rate approximate how can it be for age concerned. 2 years, it is ranging from 85 to 125. In 4 years, it is 75 to 115. As the age progresses, the heart rate gradually decreases. T wave and sinus arrhythmia, there is a juvenile T wave pattern, and the sinus arrhythmia is present in infancy and early childhood. In the next slide, I will show you the pictorial demonstration of the ECG. Yes. So this is a 4-month-old female. The ECG is showing T wave. Now it becomes in the previous ECG you all seen that there is biphasic T wave. Now the T wave has inverted in V1 to V3, and see the gradual R and S ratio is being normal. That is, the S wave is gradually becoming bigger from V1 to V3. Okay, and the axis becomes normal. That is, the 1 is positive, AVF is equiphasic. So AVF is equiphasic means that the axis is 0 degree axis. So it is a normal axis. Next slide, please. This is a 2-year-old male child ECG showing this in the widespread. Most of the leads are showing early ST elevation. That is the J point elevation. This is a normal phenomena. This is called early repolarization. And Q waves are seen normally in V5, V6. You can see these are the physiological Q waves. These are nothing but a septal depolarization. And also you can see in lead 3, these are the Q waves. And the axis is also normal. And this is sinus rhythm, and the heart rate is almost around 120. So it is 2.5 year, this ECG pattern we can see. Next slide, please. So in late childhood and as adolescent, how the ECG changes, the axis usually normal or slightly to the right, it varies. The T wave inversions, that is a juvenile T wave inversion pattern may persist from V1 to V3 into early adulthood, sorry. And that may be isolated T wave inversions in lead 3, AVL and AVF and V1, similar to adults, mostly seen in sports person, child who are participating in sports. Sinus arrhythmia is there, and early depolarization pattern, as I have already mentioned, that is elevation of the J point is seen normally in this age group. ST elevation is widespread and without any reciprocal ST depression. This is very important because in case of myocardial infarction, we can see reciprocal ST depression in the opposite leads. But here, there is global ST elevation due to early depolarization and the J point elevation. There is notching on the slurring of the J point. And there is ST changes. These are not stable, but not changing due to myocardial infarction. These are apart from the myocardial infarction. These are the physiological normal variants of the ECG. Next slide, please. So this is a ECG picture of a 7-year-old female. You can see there is a slight ST changes, ST elevation, one small square above the baseline. So it is normal variant. Along with this gradual LV dominance. There is deep S wave in the V1 to V3 and there is LV dominance in V4, V5, V6. So it means that the LV is becoming predominant ventricle as the age grows. Next slide, please. So we have already discussed that there is a right ventricular dominance in the infants. So there is tall R wave and small S waves, as I have already mentioned in V1, and also in right precordial horizontal leads. That is, if we place V3R, V4R, then there is also positive R wave, and R is to S ratio will be more than 1. Similarly, there is deep S waves and small R waves in the left leads. That is the V5, V6. Then it is deep S wave. That is the RV dominant pattern. By 1 year of age, the R wave are small in right precordium and tall in left precordium. This is the normal R wave progression. Next slide, please. So, what are the T wave changes? The rapid changes in RV pressure in first few days of life produces these T wave changes. We all know that in fetus, the lungs are not acting, so the duct, through the duct, blood is going to the DTA, and so the RV dominant pattern is represented by this T wave inversion. First few minutes after birth, the T wave is upright in V1 to V6. In the next few hours, there may be a flattening or inversion of the T waves in left lateral leads, that is V4 to V6. Over the next 7 days, the T wave vector moves in a posterior and leftward direction so that the T wave becomes inverted in V1 again and upright becomes upright in V6. Again, it becomes upright in V1 at 7 to 8 years of age. So upright T wave that persists in lead V1 beyond first week is the criteria indicative of RVH or RV strain pattern or TPHN like this. Because I am again recapitulating or I am again repeating because this is very much confusing. See, after birth, after a few minutes, the T wave is upright. Okay, in the next few hours, there is flattening and inversion in left lateral leads, and next 7 days, the T wave vector is moving leftward direction and posterior, so that it is becoming upright in V6 and inverted in V1. So if, in spite of this, if the T wave becomes upright in V1 after 7 days, then it is invariably indicative of RVH or the strain pattern. Next slide. So next slide, please. So this is a picture having 3 panels, panel A, B, and C. The serial changes in ECG with age. In the A panel, that is first left side, the ECG is obtained at 1 month of age, and there is normal sinus rhythm with right axis deviation as RBBB pattern. That is RSR pattern in V1 to V2, V3. And see, in the B panel, there is indicated by the arrow, there is a saddleback ST changes in the V3. And also, after that, at 6 months of age, the same child ECG showing a coughed pattern in the T wave in the V3. So it is nothing but a Brugada syndrome. And see, there is the QT, there is the QT interval is more than the half of the RR interval. So it is indicating of a long QT. So these are the T wave changes present in the Brugada, and this is a specific indicator of some diagnostic channelopathies, which has been already discussed by Dr. previously. Next slide, please. Now, in a preterm infant, the QRS duration is much shorter because the heart mass is very less. The muscle mass is less, the weight is less. So the QRS duration is short. Pair interval, QT interval are also shorter. The reduced QRS voltages, because small heart mass cannot generate so much voltage, so much amplitude in the ECG, because due to the less weight of the baby. Less right ventricular dominance is also there, and the right ventricular dominance again increases as the baby reaches the term. At 1 year of age, the heart rate of the premature infant is more than the term infants. Invariably, this small heart has to generate the cardiac output. So the preterm infant has a higher heart rate than a term infant. Next slide, please. Now, P wave. The P wave amplitude does not change very much significantly. At any age, if the amplitude is excess of 0.025 millivolt, that is the 2 small squares in amplitude in 2 should be regarded as exceeding the upper limit. Voltage criteria of atrial hypertrophy should only be applied when the P wave axis is normal. That is, the normal P wave axis is 0 to 90 degrees. Next slide, please. Now, what about the Q wave? The Q wave, I have already told you, this is due to the septal depolarization from left to right in a non-inverted ventricle, the normal situs solidus lipocardia. We can see Q wave in V5, V6, and also Q waves are seen in 2, 3 AVF. And it doubles over the first few months of life. The Q wave amplitude doubles and reaches a maximum at about 3 to 5 years of age and declines thereafter, and back towards the initial value of the newborn. So if we see a curve on the table that the Q wave increases in amplitude up to 3 to 5 years, then gradually declines to the newborn value. And the maximum Q wave is 0.6 to 0.8 millivolt, which is the normal range for 6 months to 3 years. Next slide, please. QRS complex, the relative right ventricular hypertrophy of the newborn regresses over first few months of life. We have already discussed. This change is reflected by the appearance of QRS complex in the ECG. QRS axis in newborn is 75 degree with a range from 60 to 160. There is invariable right axis deviation. The resultant vector is in the 60 to 160. And there is a relative rapid change in axis over the first year of life from this onwards, so that the axis becomes around 65 to 70 with a range from 0 to 110. So the right axis deviation nature is gradually becoming normal axis as the age progresses. Next slide. The QRS complex. The amplitude of the R wave in the right precordial leads of normal children decreases with age, while the amplitude increases in the left precordial leads, because it represents that the right ventricular dominant is converting to the left ventricular dominance. The LV is taking the upper hand. Similar but inverse changes occurs in the S wave. We all know that the S wave, when the S wave is prominent in V5, V6, then it is a right ventricular pattern, and when there is a left ventricular pattern, then the S wave is prominent in the right precordial leads, that is V1 to V3. Average RS ratio in V1 is more than 1 up to 3 years, as it is indicative of the right ventricular dominance pattern. And it will remain more than 1, some normal individuals, even up to 12 years, because of some sports activity or some athletes, it may become more than 1 up to 12 years of age. So it may be normal. Next slide, please.
Sorry to interrupt, ma'am. You have 3 minutes more, ma'am.
Yes, yes. So this chart, this table, this is the lead 3 and lead V6. And there are two charts, that is Davignon median score and there is Ringbeck median score. They have actually scored that from 0 to 1 month up to 12 to 16 years. If we summarize and see minutely, we can see that the Q wave increases gradually. And have a maximum value of 5 to 8 years, then it again decreases. Both the scoring system, and see, the Davignon scoring system includes male and female, but the first scoring system, that is the Ringbeck scoring system, is only for males. See here, the gradual increment in the Q wave, maximum up to the 3 to 5 years, and then it again decreases. Next slide, please. Next slide, please, sir. Yes, I have already mentioned the T wave. I will not repeat it again. The next slide. So there are some variations of the rhythm also in the neonate to adult. Variations are normal variation, that is the sinus arrhythmia due to breathing, the short sinus pauses. There may be some short pauses which are physiological and less than 1.8 seconds. This does not result in any syncope or any symptoms of the patient. There are first degree heart block and also Mobius type 1 second degree Winkeback phenomena, which may be physiological and rhythm, and some VPCs or supraventricular ectopics, that is the atrial premature complexes. These all are normal. Next slide, please. Yes, there are variations of PP interval. This is also depends on the sinus arrhythmia. As we all know that the PP interval means the interval between two P waves. So when there is inspiration, the heart rate decreases. So the PP interval also increases. There is prolongation of PP interval. Next slide, please. Yes. So in this picture, you can see that there are some P followed by QRS, P followed by QRS. These are regular. Then followed by there is a pause and then this PQRS. So this is sinus arrhythmia with varying PP interval. This P interval, that is the group beat among these 4 beats, 1, 2, 3, 4, 5. The last beat and the 6th beat, that this PP interval is more than the previous one. Next slide, please. Yes. There are also variations of the PR interval also. We can see that the PR interval ranges from 100 to 150 beats, and one could expect the PR interval to be within a range of 80 to 100. And if it is more than 180 or more than 200, we call it first degree heart block. So physiologically, the PR interval can vary from 80 to 110, the individuals, and as the age increases, the PR interval becomes normal up to 180, up to 200. Next slide, please. Now, if we see the ambulatory ECG, sometimes the PR interval becomes prolonged to 200 milliseconds, and 10% of the normal children have this Mobis type 1 winky back phenomenon. That is gradual increase in the PR interval followed by a drop beat. And in teenagers who are participating in sports, it is much more common. If we see a halter 24-hour ECG, it can be seen at the periods of rest or at the period of relative bradycardia. Next slide, please. Yes, this is the pictorial demonstration of, you can see that there is gradual increment in the PR interval from here, and then there is a drop beat. So this PP interval is long, these PP intervals are relatively equal. Okay. And this group beating, that is 1, 2, 3, 4, 5, 6. So the PQRS conduction ratio varies from 5 to 4, 6 to 5. Provided when there is the drop beat occurring. After how many QR intervals the drop beat is occurring. So it is Mobis type 1 winky back, which is very much physiological in athletes. Next slide, please. So there are some extra systems.
Joyiti, please wind up within 1 or 2 minutes. Okay.
Yes, I'm doing so. So there are some VPCs or extra systoles, that is atrial premature complexes, in case of 0.2 to 2%, and this is normal for the children. And also in case of athletes, it can be seen around 50% populations of athletes, that due to the relative bradycardia, what happens if the AV node is sleeping, then the ventricular Purkinje system gives 1 or 2 beats. So it is VPCs. Okay. Next slide, please. So next slide, please. Yes, this ECG is showing that it is a normal monomorphic VPC in an asymptomatic adolescent child participating in sports. So these are the ECG findings. This is the normal VPC in a normal athlete adolescent boy. Next slide, please. The QRS duration, as I already mentioned, it is varying from 85 millisecond in neonate to 90 to 100 millisecond in adolescent. So there is gradual increment, but it is always less than 120. And QRS duration increases from 3 years of age in a linear manner into adolescence because of the relative RBB pattern. And it is morely seen in ASDs and also top physiology after ICAT. This has been already mentioned in the disease ECG with some congenital heart diseases. Next slide. And the QT interval, lastly, I will describe that normal QT interval throughout childhood is around 410 milliseconds. It has variations among boys and girls, and age limited criteria also, Schwartz criteria, and upper limit is 450 milliseconds. We calculate Bayes' formula to calculate the corrected QT interval to diagnose the long QT syndrome. Okay, next slide, please. So to summarize, these are the indications of ECG, pediatric electrocardiography. Next slide, please. So please move my slides quickly. Yes. So there are some influence of genders. And see, lastly, I am describing that these are the different variations of ECG in adults. Like if we can divide the adults in 3 age groups from 45 to 54, 54 to 64, and more than 64, then we can see that in very elderly group, that is the green, the age 3 age group, the mostly the change is left bundle branch block due to some myocardial ischemic changes, hypertension, LBB pattern is more common. And in the second age group, that is relatively less older age group, there is ST elevation. There is more frequent heart ischemic attacks or some non-cardiac ischemic changes, like ST changes are more frequent. And the initial group, sinus bradycardia and the left axis deviations are very much predominant in adults. Next slide. Next slide, please. Sir, I am winding up. So to conclude that, standards of normal values, sir, please. Standard of normal values to help the interpretation of ECG of children has been available for many years, and it is very much physiological, and the standards should be reviewed to take an account to change the electrocardiographic instrumentations and other standardizations. The recent changes seen apparently in normal children during random 24-hour Holter are well described, but long-term follow-up and the long-term studies to be done. Thank you. Thank you, sir, for your patience hearing. And I, again, really sorry because of the technical glitches.
It's okay, I'm stop sharing. Again, we are running short of time today. So if there is any question, Joyiti, please answer them in the chat box. I will request Malvika to proceed for the next session. Over to you, Malvika.
Our next topic is white complex tachycardia, and speaker is Dr. Samajit Shomaddar, who is DM pediatric cardiologist. Done from AIMS Delhi, consultant pediatric cardiologist from BM Birla Heart Research Center, and visiting pediatric cardiologist of ICH Kolkata and KIMS Hospital, Burdwan. Welcome, Dr. Samajit Shomaddar.
Good evening, everyone, and thanks, Dr. Malvika, for this nice introduction. So, to discuss about white complex tachycardia is quite difficult in 15 minutes, but I will try to keep the practical aspects here. I have not included the treatment section because I think it's in other session. So, to define white complex tachycardia in pediatric patients is difficult because the QRS with which we see in white complex tachycardia, it's dependent on age, and a white complex rhythm in an infant may apparently appears narrow. So the QRS duration, so what is the definition of white complex tachycardia is that the QRS duration should be greater than 98th percentile for age. So let us focus in this ECG below. So this ECG apparently looks like a narrow complex tachycardia. The QRS, but this is a ECG from a neonate with ventricular tachycardia. So this is another ECG where we can see that the tachycardia is apparently looking like narrow complex, but it's actually a white complex tachycardia. So to define white complex, we have to focus on the age of the patient. So if the age is suppose is a neonate, so QRS duration, the 98th centile of QRS duration is only 85 milliseconds, and it's you can see here in this normogram that even in a 5 to 8 years old, it's only 98 to 95. So coming to the differentials in white complex tachycardia in children, the first differential which you should always consider is VT. Whenever you are in doubt, consider it as VT because VT is most dangerous and it needs urgent treatment. So among ventricular tachycardia, you can have a monomorphic VT where all the complexes are of similar shape and axis. The most common may be idiopathic ventricular outflow tachycardia or fascicular VT or other monomorphic VTs. Less common or rarely seen in pediatric age group is bidirectional VT, which is seen in CPVT or in rarely in digitalis toxicity. Polymorphic VTs are also relatively uncommon, and we can see in long QT syndrome with torsades. And
sorry to interrupt, sir. Sir, keep your microphone slightly away from your face. It is making some noise.
Okay, now it's clear.
Yes, sir. Yes, sir.
And ventricular fibrillations. Among SVTs, which looks like white complex are SVTs with rate-related aberrancies, SVTs with pre-excitations like antidromic tachycardia, or SVT with bystander accessory pathway with pre-excitations with atrial fibrillations, or other causes that which are mimickers or aberrancies. So coming to ventricular tachycardia. The ventricular tachycardia is defined as 3 or more consecutive beats which are originating in the ventricles and having a rate of at least 120 per minute or more. And lower ventricular rates with the ventricular rhythm is called as idioventricular rhythm. VTs can be divided into sustained VTs when it lasts for more than 30 seconds, or non-sustained VT if less than 30 seconds. Monomorphic VTs are having constant appearance, as I told, and polymorphic VTs are changing QRS shape axis. So how to identify VT? So there are certain points by which helps us to identify VT, and whether it is a VT or SVT, we can differentiate. So the most common and the most useful is to look for ventricular-arterial dissociation. That means the P waves and the QRS will be independent of each other. Here in this picture, we can see in the ECG that the P waves are not related to the QRS complexes in both the strips. So this indicates a ventricular tachycardia. Again, in this ECG, you can see it's difficult to identify P waves, but if you focus minutely, you can see that the height of the T waves are different in different, QRS complexes. That means those are superimposed P waves. So here also, this is a strip of a VT with AV dissociation. Another strip of VT with AV dissociation, you can see the black arrows showing AV dissociation. So can AV dissociation be relied upon solely to identify VT? No, because AV dissociation, one study showed that AV dissociation is clearly seen in only 27% of cases. And even when AV dissociation is present, the independent P wave may be difficult or impossible to recognize in the clinical tracings, as we have seen. And rarely, junctional tachyarrhythmias with bundle branch block may be dissociated from an independent sinus rhythm. So we have to look for other things. And then comes the concept of fusion beats and capture beats. So capture beats are beats which occurs when the sinoatrial node transiently captures the ventricles in the midst of AV dissociation, producing a QRS complex of normal duration. So a sinus beat in the middle of the VT get a chance to conduct itself and giving a normal sinus beat. And the fusion beats is somewhat is a fusion hybrid complex of a sinus as well as a ventricular beat. So let us see them. In this tracing, you can see the initial black arrows signifying a beat which is a fusion of the, a hybrid of the QRS, the ventricular beat as well as a supraventricular beat. And the second two are more looking like a sinus beat. So they are capture beats. Here also, you can see that after a run of ventricular tachycardia, we are seeing a different beat in the first red arrow. So this is a capture beat, which looks like a sinus beat. And again, in the next red arrow, you can see a fusion of the two. So this is a fusion beat. So these are very specific for VTs. So if we can identify a fusion beat or capture beat, then we can be pretty sure that this is a VT and not a SVT. Now, is there any role of adenosine in VT? So general concept is that adenosine doesn't work for VT, and it's quite true, but adenosine can help largely in diagnosing the VT. How adenosine, when you give adenosine, it causes AV block. So if it causes a retrograde AV block, it gives a chance for a sinus beat to get conducted. That what we can see in the middle of the strip, we can see a sinus beat which is conducted, and again the run of the VT with AV, and it unmarks the AV dissociation. So then we can diagnose that it's a VT, not a SVT. And adenosine also is helpful. I think Malavika will talk tomorrow in outflow tract VTs. So this is the bit which got transferred after adenosine. So sometimes it becomes very difficult to differentiate between them. and we can need EP study also to differentiate. But still, let us see how with the ECG, surface ECG, we can differentiate. So in a LVP pattern of wide complex tachycardia, if we see in the V1 or V2, if the R in V1 or V2 is more than 40 milliseconds in duration, or greater than 60 milliseconds from QRS onset to S nadir in V1 and V2, and if there is a notched downstroke S wave in V1 and V2, or any Q wave in V6, then it favors towards VT. In a RBP pattern of wide complex tachycardia, if the V1 is having a monophasic R wave, or a QR pattern, or a RS pattern, or if the R is greater than R dash, or in V6 if R by S is less than 1, or there is a QS pattern or QR pattern or monophasic R wave, then it favors VT. On the other hand, if there is a triphasic wave in V1 or a triphasic wave in V6, then it favors SVT. So to differentiate VT or SVT with aberrancy, Brugada came with a criteria. So in the flowchart, and it's quite sensitive and specific. So in the flowchart, you can see that if there is absence of an RS complex in non-precordial leads, then it's likely VT. And if no, then you have to go to the next question, whether R2S interval is greater than 100 milliseconds. If yes, this is VT. If there is atrioventricular dissociation, as we have already discussed, then it's a VT. And if the morphological criteria VT is present in both V1 and V12 or V6, then it's VT. But still you can't, with 100% surety from surface ECG, sometimes we can't differentiate between them. And there comes the role of EP study. So this is VT or SVT. Here we can see that this is a broad complex tachycardia, but the tachycardia starts with a premature atrial wave. And in the V1, we can see the R dash is greater than R. So this is a SVT with aberrancy. So types of ventricular tachycardia commonly seen in pediatric age group is the one common type is incessant idiopathic infant ventricular tachycardia, which you see in 1 month to 3 years of age, and it's called incessant when more than 10% of the beats are having ventricular beats. It's associated with poor ventricular function, most of the time presents with cardiomyopathy, low EF. An underlying cause is a microscopic posterior left ventricular tumor. The ECG will show a typical RBB morphology with superior axis because the origin is from the left ventricle in the posterior part of left ventricle. Treatment in acute condition, we can give IV lignocaine, amiodarone or DC shock, and for maintenance, we can use oral amiodarone, flecainide or beta blockers. This is a incessant idiopathic infant ventricular tachycardia where you can see that the RS pattern here, and also the AV dissociation is seen. Idiopathic left ventricular tachycardia affects older age group and more common in boys than girls. And symptoms are palpitation, dizziness, dyspnea, presyncope, and it may occur at rest but often triggered by exertion or excitement. The origin is in the Purkinje system, low on the left ventricular side of the septum, in the region of the posterior fascicle of the left bundle branch. So the ECG will show RBB pattern with superior axis. As it is originating the Purkinje system, the QRS complexes are not very broad. Now this tachycardia responds to verapamil. So this is the idiopathic left ventricular tachycardia. You can see the RBB morphology, but the tachycardia looks like narrow. Idiopathic right ventricular tachycardia less common, also seen in the adolescent age group. Symptoms are same. ECG will show a left bundle branch block pattern with inferior axis, and it's often suppressed at higher rates and workloads. The important differential for this tachycardia is arrhythmogenic right ventricular cardiomyopathy. It's extremely rare in the pediatric age group, but we have to keep in mind. So we have to take family history where there is history of any sudden deaths or not. And if there is features of cardiomyopathy, we may have to go for MRI, cardiac MRI, echocardiography, etc. This tachycardia also responds well to IV verapamil. So this is the tachycardia with LBB pattern and superior axis. You can see the upright waves in, inferior axis, upright waves in the inferior leads and LBB pattern. So coming to polymorphic ventricular tachycardia, long QT syndrome is most common in our patient group. And the characteristic ECG features of the congenital long QT and QT interval prolongation and abnormalities of T-wave morphology. It's caused by mutation in the encoding genes, and frequency among genotype positive patients are 40 to 45% have long QT1, 40% to 45% have long QT2 mutation with KCNH2 gene, and long QT3 accounts for only 5 to 8% of the known cases. So long QT, what is the danger of long QT? Because it precipitates torsades. So torsade is a polymorphic ventricular tachycardia associated with prolonged QT interval, reflecting prolonged cardiac depolarization. It's potentially life-threatening and can be sustained or degenerates to behave. The mechanism is attributed to T-guard activity due to early after depolarization. The heart rate of torsades range from 150 to 250 beats per minute with twisting of the QRS complex around the baseline. Treatment is we have to stop the offending drug. IV magnesium has role in this, and lignocaine mexilatin. Amiodarone is avoided in this situation. Long-term management is beta blocker and ICD implantation. So this is a typical ECG of a torsade. You can see the polymorphic form of the VT, and the VT originates after a rhythm of bradycardia. So can we identify the or get an idea of the genotype of the long QT from the ECG, and is it helpful? Yes, it's helpful because genotype identification ECG helps stratifying molecular genetic study, and it's very studying all the mutations are quite difficult. So an evaluation of several ECG of family member increases the likelihood of finding a typical pattern. So let us see how we can identify genotype from the surface ECG. So in a long QT syndrome 1, we will see early onset broad-based T wave, like in the figure. In long QT2, we will see bifid T wave. Not always, but these are the characteristics. And long QT3, we will see long isoelectric ST segment. After that, we will see a late appearing T wave. So these ECG tracings helps us to identify which type of long QT is present, and in the family member, if same thing, same pattern is seen, then we can be more sure about that, and we can go for testing that gene only. So what are the risk factors for torsades in a long QT? Is the length of the corrected QT interval. The long QT 1 and 2 with long QT syndrome, males are more prone, especially with long QT 3 before puberty, and females during adulthood, pregnancy, and postpartum period. If there is family history of sudden death and family history of long QT syndrome, history of syncope if present, and history of resuscitation. Another very rare form of polymorphic ventricular tachycardia, which are mainly seen in the adolescent age group, is catecholaminergic polymorphic ventricular tachycardia. This is rarest but most dangerous ventricular arrhythmia encountered in childhood. High risk of syncope and sudden death is present. It's an autosomal dominant inheritance, and 20 to 50% of cases show a mutation in the cardiac ryanodine receptor gene. It's precipitated by exercise or isoprenaline infusion, and ECG will show a bidirectional ventricular tachycardia or may also show polymorphic VT. Treatment is beta blocker and many times needed ICT. So these were the ventricular tachycardias which are commonly seen. Now coming to the supraventricular tachycardia, which mimics like a VT, is antidromic AV reentry tachycardia. It's uncommon, but we have to keep this in mind while analyzing the ECG. It will show a regular, and the QRS is minimally pre-excited.
Sorry, sir. Sorry to interrupt. You have 2 minutes more, sir.
Okay. I will conclude. So, and it will show a very prominent delta wave. T waves are usually very difficult to see with a right-sided pathway, the QRS resembles LBB pattern with slurred upstroke. And antidromic AV reentry tachycardia will stop with adenosine if retrograde conduction is over the AV node. And it rarely requires intravenous flecainide or cardioversion if two accessory pathways are involved in the circuit. So this is an example of an antidromic AV reentry tachycardia. This is a LBB type, right-sided pathway. We can see the extreme regularity of the tachycardia, and there is no, we can't detect any fusion wave, and we can't detect any capture waves or AV dissociation. This is another antidromic AV reentry tachycardia with RBB type pattern. Here also you can see the triphasic waves of SVT as well as no AV dissociation. Another very lethal tachycardia, which is very rare, but I think it's needs mentioning, is Wolff-Parkinson-White syndrome with AF with Wolff-Parkinson-White syndrome or P excitation. So how to identify this is the irregular pattern of the complexes. So this is a very lethal tachycardia, and it can very quickly transfer into VF and cardiac arrest. So in any case of AF with pre-excitation is an emergency. We have to terminate this with DC shock, and drug which is specifically used is procainamide. So here, this is one condition where adenosine can worsen the tachycardia because it will block the AV node but will not the accessory pathway. So adenosine or any AV node blocking drug should not be given. So to conclude, I will say that white complex tachycardia are not very common but serious in pediatric population. That doesn't look always very white. And whenever in doubt, consider the working diagnosis of VT to start treatment of VT as soon as possible. And adenosine is helpful in diagnosis of white complex tachycardia, even if it helps to terminate. And QTC should be routinely calculated in non-pediatric ECGs. Thank you.
Thank you, sir. Our next topic is chest X-ray in acquired heart disease. Speaker is Dr. Ishita Mojumdar from IPGMER Hospital. She is faculty of IPGMER Hospital Cardiology Department. She has done her MD Pediatrics and DM Cardiology from India. Welcome, Dr. Ishita Mojumdar.
করার সময় পেন্ডিং দিয়ে কোনো লাভ নেই, সেই জায়গায় করতে হবে, রাত্রে একটু করে দিয়ে কষ্ট করে। এবার রোজার ব্যাপার থাকে, এবার যার কারণে এক্সট্রা টাইমটা একটু
Am I audible? Hello?
Yes, you are audible.
Okay. Okay, ma'am.
Where is Ishita? Ishita, please share your screen.
Hello. Can you hear me?
Yes, ma'am. You are audible, ma'am. You can share your screen, ma'am.
Yes, I have started sharing.
Yes, ma'am.
Can you see the share?
Yes, ma'am.
Rishita, continue. You are audible and your slides are visible also. Please continue.
But next, yes. So today my topic is chest X-ray in acquired heart disease. So a systematic approach is directed toward discerning the pertinent findings from the radiograph and for each finding narrowing the array of diagnostic considerations. So once you have taken a proper history and have gone through the patient with examinations and have done the ECG, the next step is chest X-ray. So before proceeding for it, we have 5 steps for systematic approach. So once you see a chest X-ray, look at the thoracic muscular structures, then the pulmonary vascularity to look whether it's a pulmonary arterial or a vascular abnormalities and the degree of severity. Then look for the overall heart size, the specific chamber enlargements, and look for the great arteries. So for the thoracomuscular structures, we can get an idea about whether there is any rib or sternal deformities or sternal wire sutures, which is we usually get for the operated cases where we can see the sternal wire sutures, or whether there is a sternal deformity, specifically for the pectus, which gives a clue for the Marfan and an inherent insight whether there is an aortic regurgitation or any aortic dilatations or a mitral valve prolapse. Another thing which comes in mind is the narrow anterior posterior diameter. When we say that it is narrow, what is that? In a lateral view, if we see the sternum and the anterior border of the vertebral and the distance is less than 8 centimeter, or the ratio of the transverse diameter, which is measured in the frontal view, to the AP diameter, which is measured in the lateral view, exceeds 2.75, then it is called as narrow anterior posterior diameter, which is seen in case of pectus excavatum or straight back syndromes. So next is the pulmonary vascularity. Here 3 steps. First is the type of abnormality, which in congenital cases we see for the pulmonary arterial overcirculation or undercirculation. And in case of the acquired ones, which is more important, is the pulmonary venous hypertension. Then is the severity of the vascular abnormality, whether it is grade 1, 2, 3, which we'll be discussing. Another thing is the whether it is symmetrical, asymmetrical, or even focal in nature. So pulmonary venous hypertension, in which we see the abnormal redistribution, like normally the upper lobe vessels are narrow in comparison with the lower ones. But pulmonary venous hypertension, initially it becomes at the equal size, which is called as equalization, followed by it becomes larger. The upper lobe vessels become larger, which is called as cephalization, which we can see from this views. Cephalization of the pulmonary vasculature, followed by there is peribronchial cuffings, interstitial edemas, which are seen as early A and B lines, pleural effusions. Then is the interstitial edemas, which we can see, and as well as the alveolar edemas and appearing as the bat wing appearances. So pulmonary venous hypertension can be graded as 1, 2, and 3. 1 in which there is X-ray finding collaborating with mild pulmonary edema with equalization and cephalization, and which correlates with a left atrial pressure of around 12 to 19 in case of acute cases like an acute MR in a rheumatic heart disease, or in case of chronic cases, which are chronic rheumatic heart disease patients presenting with chronic MR, in which it is around 15 to 25. PVA2 is in which we have interstitial markings which are prominent, interstitial edema, curly A and B lines, peribronchial cuffing, loss of hilar angle, enlargement and indistinctness of hilar, subpleural edema, loss of visibility of much of the descending branch of the right pulmonary artery. And it correlates with a left atrial pressure of 20 to 25 in acute cases, while 25 to 30 millimeter in case of chronic cases. And 3 is one in which we can see for confluent acinar shadows or alveolar pulmonary edema, perihilar alveolar filling, lower lobe or more generalized alveolar filling, and an LA pressures of around more than 25 in acute and more than 30 in chronic cases. So some more examples. In this case, what we can see is a grade 3 pulmonary venous hypertension with a normal heart. So this is a case in which this occurs as a result of an LA myxoma, which was obstructing the left inflow. This is another example in which we can see that in the right part there is edema, but it is only localized to a small area. It is occurring as a result of the metastatic carcinoma which was obstructing the pulmonary vein. In this X-ray, which we can also see, there is the pulse generator and the leads, RV lead, which is in situ. Next is the cardiomegaly, the chest X-ray, which has already Dr. Devashree has talked yesterday. When we measure in the right side from the right heart border to the midline and from the left heart border, maximum left heart border to the midline, if we add up these two and divide it by the maximum thoracic diameter, which is measured from the inner diameter from the inner borders of the ribs of the right hemidiaphragm to the opposite side. So this is called the CTR ratio, which is in case of children's more than 0.5 has been considered as cardiomegaly, and for older children's for 0.55. While it is not valid for neonates or infancy, it is the cardiac volume which is to be taken into consideration for those children. Next is the ventricular enlargements. Left ventricular enlargement is characterized by the apex looking down and out. While in case of right ventricular enlargement, it is the upward looking apex, which is more convenient. And in the lateral view, if we get that the apex, the anterior sternum is almost occupied, and that is more consonant with the right ventricular hypertrophy. Next is the left atrial enlargement, in which there is a double contouring of the right heart border. There is straightening of the left heart border due to the left atrial enlargement, which is present in usually at the left bronchus below the just or below the left bronchus. Another is the left atrial enlargement, which we can measure from the mid part of the double contour to the middle part of the left bronchus. If it is more than 7 centimeter, it is denoted as left atrial enlargement, and it is denoted and it is correlating with the echocardiographic findings of an enlarged LA. So LA enlargement signs are retrocardiac double density greater than 7 centimeter, that measurement, as I've already told, enlargement of the LA appendage, splaying of the carina and or elevation of the left bronchus, horizontal orientation of the distal portion of the left bronchus, posterior displacement of the left upper lobe bronchus as seen in the lateral X-ray. So right atrial enlargement is considered when you can measure it is the right atrial border is mostly covered and has exceeding more than 60% in length of the total right atrial border. We considered it to be a right atrial enlargement. So great vessels, in this we can see this is the ascending aorta, which is enlarged, and usually they are associated with the aortic valve diseases, ascending aorta. And the main pulmonary artery, after the aortic knuckle, it is the main pulmonary artery which is enlarged. We can see in case of pulmonary artery hypertension or in case of congenital pulmonary stenosis, in which the MPA gets dilated. So radiographic classification of acquired heart disease consists of small heart or a large heart. Small heart, in which comes most commonly is the mitral stenosis, juvenile mitral stenosis, which is also very common in the pediatric population. The aortic stenosis, which is also which is rare in case of acquired, which is rheumatic isolated aortic stenosis, is very, very rare in the pediatric age group. It is mainly the bicuspid or the unicuspid valves which causes aortic stenosis in the pediatric population. Hypertrophic cardiomyopathy can present in pediatric population. Restrictive cardiomyopathy, which occurs as a result of the thalassaemic patients, which usually present, and the constrictive pericarditis, which occurs most commonly as a result of the tubercular pericarditis. Large heart syndromes, with their aortic regurgitation, which is common in the pediatric population with the rheumatic heart disease. Usually they are associated also with the mitral regurgitations. Mitral regurgitation, tricuspid regurgitation, which is mostly tricuspid valve prolapse, or even in very few rare cases of rheumatic involving the tricuspid regions. High output states like anemia, thyrotoxicosis, which presents with large hearts and with large hearts in case of pediatric population. Congestive cardiomyopathy, like the dilated cardiomyopathies, which we most commonly are getting in these days with the viral myocarditis, and the pericardial effusion, which is also very common. So mitral stenosis, in this usually normal musculoskeletal system, especially only in those cases musculoskeletal system we will get abnormal when they are as a part of the MPS, mucopolysaccharidosis syndrome. Pulmonary venous hypertension, which we can see it due to the catheterization and the alveolar interstitial edemas which are present, straining of the left heart border and the double contour which we can see. And as a result, it is a small heart in comparison to the large hearts which we usually see. And in few cases, features of left atrial interval already I have discussed. In case of aortic stenosis, this is a small heart which we can see, but the ascending aorta is little dilated. And another thing which we can see is the calcification. It is usually rarely seen in pediatric population, but in the older age groups and mostly the congenital ones with bicuspid or the unicuspid can present with stent calcification in early age. Hypertrophic cardiomyopathy. These usually presents with cardiomegaly with a left ventricular hypertrophy, with left ventricular enlargement, and in few cases with the dilated ascending aorta with a prominent aortic narcle because they can be associated with a bicuspid aortic valve. So constrictive pericarditis, cardiac shield may be enlarged or due to existing pericardial effusion. Pericardial calcification can be seen in minority of patients with tuberculosis, but is not diagnostic of constrictive pericarditis. Pleural effusions are common. Mitral regurgitation, in which we usually get a large heart. And these are very common findings, and these children present with sudden onset of shortness of breath and fever and with a large heart. So these presents with pulmonary venous hypertension and pulmonary arterial hypertension also as a result. Aortic regurgitation, which is usually occur as a result of acute and chronic rheumatic heart diseases, in which no chest deformity, pulmonary venous hypertensions are common, cardiomegaly is a common thing, and in which usually we also get a left atrial enlargement because AR are always associated with a mitral disease in rheumatic heart diseases. Left ventricular enlargement and ascending aorta being dilated. Tricuspid regurgitation usually associated with a left side also involvement because isolated tricuspid involvement in rheumatic is very, very, very rare. So dilated cardiomyopathy, which is very, very common nowadays as a result of the various viral diseases which is occurring, in which we get a large heart, and along with that may be associated with the pericardial effusion, dilated left atrium and left ventricle, pericardial effusion or a pleural effusion, and pulmonary venous hypertension. Pericardial effusion, normal cardiac silhouette unless there is moderate effusion. With larger effusions, the anterior posterior cardiac silhouette assumes a rounded flask-like appearance, water bottle sign. Lateral views may reveal fat pad sign, a linear lucency between the chest wall and the anterior surface of the heart resulting from separation of parietal pericardial fat from epicardium. Another child who presented at 3 years of age in an earlier was a follow-up case of different department, presented this time with a large heart and prior history of ascites and pleural effusions was also there, was left ventricular hypertrophy. As we can see, it was downwards, and with pericardial effusion was earlier present, this which X-ray is not present with me. And there is few features of pulmonary venous hypertension. So Takayasu can also present with a large heart because they have varied presentations involving from cardiac, pulmonary to various other arterial systems. So another example is pulmonary embolism, in which we get enlarged pulmonary arteries, which is known as the flexner sign, Hampton sign, peripheral wedge or airspace opacity and amplifies lung infarction, Westmarker sign, regional oligemia, specificity of 92%, which is the most specific sign, pleural effusions, which are also present, knuckle sign, Pala sign, enlarged right descending pulmonary artery, the Chang sign, the dilated right descending pulmonary with sudden cutoff. So a small summarization of all, the small heart disease, if you get a left atrial enlargement, think of mitral stenosis or any diseases with a reduced LV compliance, like the restrictive cardiomyopathy, hypertrophic cardiomyopathy, or constrictive pericarditis. If you get a left atrial enlargement signs and with a big heart, look for mitral regurgitation. And auscultation will just help you differentiating these things. And if you get an aortic enlargement, aortic ascending aorta enlarged, think of aortic stenosis or an large heart with aortic regurgitation. And auscultation will just help you differentiate between the two. And other myocardial and pericardial diseases, acute MI is very, very rare unless the more commonly the Kawasaki's, which we are getting, who are presenting in a very late stage, can present with acute MI in these patients, or an alka-pause, which can present with acute MIs. Restrictive cardiomyopathy.
Sorry, ma'am. You have 3 minutes more, ma'am.
Yes, I have already done.
Okay,
Myocardial with large hearts, it is the dilated cardiomyopathy, which you must always think of right ventricular failure, which may occur as a result of already underlying right ventricular cardiomyopathy or an Epstein anomaly, which is there. So thank you for your patient attention, and segmental approach is the key to success for diagnosing anything. Thank you.
Thank you, ma'am, for your nice presentation.
Ishida, I have got a question. May I ask you?
Yes, sir.
In the Cardi's A line, you have put it in the mid zone on the right side. Actually,
Usually
the Cardi's A lines are seen in the apex.
Apex.
In the apex, but you in your X-ray, it has been pointed in the mid zone.
Yes, that is the X, which was little. Apex is usually the basal parts is the B lines, and in the apex is the apical A lines, Curly's A lines.
So we call it A, B, C lines. A for the apical, B for the base, and that will be just a perpendicular to the pleural surface. And central or the crisscross, we call it the woody opacities, we call it the Cardi's C line. The demarcation was not there.
No, yes, it was scoping.
Anyway, it was a very nice presentation.
Thank you, sir.
So, Malavika, I think we don't have any session today. So
Yes, sir. Yes, sir.
Yes,
so
we have to keep the Lopa session tomorrow because of the time constraint, and Lopa will present tomorrow.
Okay.
Okay, sir. Okay.
So tomorrow there are very interesting session. The third day, the end of our workshop, and it will be followed by a very interesting session of quiz, and that will be very interesting. So please join on. Today I have seen the participants are very low in number. So from tomorrow we expect there will be larger number of the participants. So thank you everybody, all the panelists and the speakers and the expert, particularly Dr. Ditobrata Das, and today's convener, Dr. Lopamudra and Dr. Malavika. So we should call it a day. Thank you and good night. See you tomorrow, same time at 6 p.m.